Hello, everybody. Welcome to the session where we are going to discuss the very important topic of how to anticoagulate or not to anticoagulate the patient after TAVR. We have the world expert of two major trials, the PI of two major trials, debating this particular topic. And they are not just experts, but passionate about this particular research. And first, we are going to hear from Dr. George Dangas talk about that in this particular situation, there is no need for NOAC, just aspirin alone is enough. So George, please go ahead.
Thank you so much, Samir, for this great introduction. And I'm very happy to be part of this very important session in TCTAP Asia Pacific. My best regards to everyone in Korea, all the way from snowy New York. This is a very interesting subject and started long ago with random observations here and there of valves and valve leaflets being thrombosed, usually in different spots, and perhaps at sometimes resolution of this phenomena by anticoagulation. This became a bit nervousness for everyone. There was a jump and a concern of potentially what these clots might be, but we must remember that this phenomenon is not new. It existed. We're going to go over it in other sessions. This is more of a pointed debate, but predominantly we need to understand that this was an imaging-driven concern because of the first time we had this 4D dynamic CT angiography of the valve enabled by the technology, and the first time we're really able to see up close and personal these aortic valve leaflets that seem to be having problems no matter what kind of valve it is here and there. The pathophysiology of valve thrombosis, prosthetic valve thrombosis, is an interaction between surface hemodynamics and hemostatic factors in a very complex interplay. Most importantly, recently again, just last year, we found out that if you do not alter the therapy in any way and just image people serially, this phenomena come at let's go. And by the first month, some people do have it, and by 1 year, maybe about a quarter have it, but those who have it at 1 month may not necessarily have it at 1 year, and those who have it at 1 year might have nothing at 1 month. So there is a fluctuation of this imaging phenomenon, which of course is not so closely related to strokes and TIAs as we originally thought or as we mostly feared. The guidelines are informed primarily by expert consensus, and that's why there is still a debate based on the concerns and also based on the absence of larger trials. Let's review the two kinds of people: successful anticoagulation, TAVR, and no underlying indication for oral anticoagulation. And first of all, to review a retrospective study we did a couple of years ago, we published it out indicating that the clopidogrel loading, that was a very, very popular way to start a TAVI before the procedure, was actually related mostly to vascular complications. They didn't really offer any protection at all in any way we could see. Of course, due to the randomized, non-randomized nature of the study, that was inconclusive. Nonetheless, this has been very much in line with a series of small randomized trials that found that clopidogrel addition to aspirin is mostly adding bleeding complications and nothing much. And again, in all those studies, the risks were initially, or the first few days after the procedure, perhaps mostly related to the clopidogrel loading again. And in the larger of the series of these trials, in the POP-TAVI cohort A, again, the flavor the same. They treated clopidogrel for 3 months, starting with a pre-procedural load for the most part. And the flavor was a lot of bleeding up front. The clopidogrel, no activity with either one further down the line, clearly a significant reduction over the time. And as far as the protection all this bleeding might afford us, nothing much to talk about. In fact, particularly in the beginning, not a lot of difference at all. Then we studied in collaboration with several of the participants of this session, in this very provocative study, the Galileo, introducing a regimen of medium or low dose anticoagulation with daily rivaroxaban only 10 milligrams. Let's remind everyone the full dose for AFib is 15 to 20 milligrams daily for this agent. And we gave it for 3 months and therefore continuing afterwards with solely rivaroxaban as a control, the dual antiplatelet therapy. In the end of the day, we didn't have much success with this regimen, particularly because there was an increased mortality in the rivaroxaban arm and particularly in the longer term. The bleeding was trended to be also on the negative side for this more intense anticoagulation. So it seems like the simpler antiplatelet regimen was, in the end of the day, more of a winner here. Now going into oral anticoagulation patients who require it regardless of the TAVR, it's a different, distinct population. So far, we have 1 clinical trial and pending other 2, which I'm not going to comment on because we expect results this year. One from Dr. Collet, who's giving the talk next to mine, as well as another study headed with myself, as well as one of the panelists of the study. Hopefully later of this session, hopefully we'll have those results at the end of the year and discuss them in TCTAP Pacific 2022. But as of now, cohort B of POP-TAVI indicated that additional clopidogrel to an oral anticoagulant did not offer much, as you can see on the right side, and cause a lot of bleeding complication. And again, let's be very clear that it was started pre-procedure. So a lot of those interference is related to the pre-procedure regimen more so. So let me rest my case for this short debate, indicating that the instance of lethal thrombosis has raised a lot of concerns. However, we know now there's no immediate stroke or TIA risk. There's another story where it's related or not to long-term durability. That's a different story, not part of this debate, and definitely does fluctuate this phenomenon over the time, even regardless of the kind of antithrombotics we give. Clopidogrel loading in particular has been associated with more bleeding and no obvious benefit in any way in stroke prevention or any others. Experimentation with a low-dose antithrombotic, such as a 10 milligram daily rivaroxaban, had an effect on the valve, but did not fare so well at the clinical part of these patients. And finally, the oral anticoagulation monotherapy seemed to also be a winner in addition to its combination with, in comparison with its combination with clopidogrel in the popular TAVI trial. So in brief, we're waiting for additional large-scale trials in this very interesting area, but so far it seems like minimalistic approach is a winner. Thank you for your attention.
Outstanding, George. Can you just highlight that the 2 trials that what are we waiting for, and what are the most not that we are going to discuss the results, but just to say that what are the most important things that we are looking forward to during this phase?
Yes, first of all, the simpler one of the 2, the one that Nicolas van Mieghem and myself lead up, is the envisaged TAVI-AF that has a very simple entry criteria. TAVR in AFib patients require anticoagulation, randomization into edoxaban 60 milligrams or 30 milligrams if there is a reason for renal insufficiency versus a warfarin regimen. And there's some clauses of if there's a recent stent, there may be a stratification to receive some antiplatelet and all that. And we have roughly about a year of follow-up, a year to 15 months of mean follow-up. And we hope to have results in ESC 2021. The other study will be presented by Professor Jean-Philippe Collet and his associates from France. Is mostly based in France, as my understanding. It may be in another European country, I'm not so familiar, but it studies apixaban as a full dose, 5 milligrams twice daily, and has 2 control groups. If the patient has indication of anticoagulation, warfarin. If patient has no indication of anticoagulation, either single or dual antiplatelet regimen. But regardless of the either control is used, the active arm is common for both of these populations, and it's apixaban 5 BID. Very interesting design, and I'm sure it would be essentially 2 studies presented at the same time of some sort. These are little different populations according to control group.
No, this is a very exciting time. Maybe we can ask Lars that I know that you have been involved in from the beginning in the leaflet thrombosis and how the valves are. We have found in these bioprosthetic valves that there is leaflet thrombus. What do you understand? What is your current strategy of investigating this? So 2 questions. One is that when you discharge the patient, what do you use at the current time? Do you use single antiplatelet therapy or dual or anticoagulation in any specific population? And then do you really, other than the research side, do you do a CT scan or something like that to investigate these patients?
Yeah, thank you, Samir. First of all, I would say we have now quite solid evidence that the patient population we're currently treating with TAVI has an increased bleeding risk. So we only give aspirin as monotherapy after a TAVI procedure. Of course, there will be patients who have indication for dual antiplatelet therapy due to ischemic heart disease and so on. But as a routine, it's only going to be aspirin. Coming back to the subclinical leaflet thrombosis, again, just remember we're talking about 2 kinds of thrombosis. There's this, you could call it clinical valve thrombosis with high gradient and often symptoms, and you need to treat that. I think everyone knows it's going to result on anticoagulation, whether it's going to be in vitamin K antagonist or a NOAC. But the more common phenomenon we are talking about is this subclinical leaflet thrombosis. And as George nicely showed, it's something which was a little bit randomly picked up on 4D CT scans. And we know it's present in all kinds of aortic bioprosthetic valves, both surgical valves and transcatheter valves. So far, we have no evidence it's going to impact the clinical outcome for the patient with regard to stroke, durability, or even progression into subclinical leaflet thrombosis. So, of course, you can resolve it by putting the patient on anticoagulation, but we have just seen that anticoagulation is going to harm these patients. So I think for the time being, outside clinical studies, don't look for it. And if you see it, don't treat it as long as it's subclinical. Of course, if you see a patient who have an increased gradient and symptoms, that's another story.
What about you, Nicolas? What is your typical take on this? What are you doing?
Well, we, following the current literature, we dismantled the use of antiplatelet therapy. So there is no place for DAPT after TAVI for patients who are not on oral anticoagulant therapy. And then conversely, in patients who have an indication for oral anticoagulants, we give NOAC in monotherapy, or warfarin if they have a mechanical mitral prosthesis, for instance. But I think what is still a little bit debatable maybe is that what happened in Galileo, was it a combination of rivaroxaban with the antiplatelet drug that caused all the mayhem? And so what we're also doing in Rotterdam at this point in time is a single center mechanistic study where we are looking into the value of edoxaban for 3 months instead of aspirin in a non-randomized fashion. But what we'll do is we put the patients on edoxaban and do a CT scan 3 months after the valve implant to see whether we can mimic the powerful data from Galileo 4D, that there is hardly any leaflet thickening or leaflet thrombosis, but at the same time have no bleeding penalties. So I think what we've learned, at least from in our experience, is that we have to be very, very restrictive with antiplatelet drugs.
No, that's good. And do you do routine CT surveillance of any of the patients?
Not routine. I think we have 30% almost. I think 1/3 of the patients do get a follow-up CT. It depends on the indication. For instance, with bicuspid valves, we typically do it, and in some selected sets of other patients, but not routinely in all.
I have a low threshold for giving 3 months of anticoagulation for patients with valve-in-valve, or if the sinuses are very small, or the, these are the, again, not very well documented that this is the right thing to do or not. But if the patient is a low risk of bleeding and they have this, then I agree with you that I do not use antiplatelet therapy if I'm going to give them anticoagulation, most commonly with a NOAC. How about in Korea? What is the strategy?
Yes, in our country, we usually prescribe the DAP therapy for if a patient is requiring anticoagulation. We prescribe the NOAC, and recently we complete our ongoing trial. We're gonna introduce the TAVR trial. It's targeting 230 patients. We randomization. One arm is edoxaban versus the standard arm is DAPT, aspirin, and clopidogrel. We already completed 230 patients, the primary endpoint, and the 6 months leaflet thrombosis routine screening of CT at 6 months. And then we simultaneously check immediate first MRI and the 6 months follow-up MRI, as well as we check the neurocognitive function test, MOCA and this, something like that. And we initially planned after release of the Lancet journal and the Lars Sondergaard published the recovery and safety registry at the time, although the study was observational study, there was some signal of leaflet thrombosis was associated with some increased risk of stroke or TIA. So, and we at the time we started the merit of advantage of the TAVR trial might be maybe first the trial mechanistically the explanation for leaflet thrombosis as well as MRI detected the brain something and neurocognitive like that. And still people now and the guideline as well as the evidence is still lacking. We now try to follow the conventional guideline DAP therapy. Patient not requiring oral anticoagulation, patient like AFib, something like that, we prescribe the NOAC therapy.
So you're still using DAPT? That's what
still using DAPT.
We have stopped using DAPT for a while also, like what Nicolas is saying and Lars is saying. Now, do you have, this is a question for anybody, to say that do you feel that there is a difference between the supraannular valves and annular valves in terms of how you, because when you design these trials, this is a little bit of a challenge because at least my personal, I have some biases, but maybe I want to hear you guys to say that is there a difference in your mind with respect to supraannular versus annular valves or self-expanding and balloon expandable valves? Because right now we are using only 2 of them.
Well, I can tell you that in Galileo, and that's in part is in the supplement of our paper, there was no difference between the valves in any way, or no interaction with any kind of therapy, although it does seem somewhat plausible that the different hemodynamic profile of the valves may support something like that. But in the end of the day, we didn't see them. Perhaps what one can say that the certain, either the smaller or the very big valves, they may have some problem. Number one, the smallish because of the constriction of the neosinus, and the bigger ones also because maybe the neosinus is too wide and the flow is just, I don't know, too stagnant or something. And there may be an interaction with CHF as well and the ejection fraction. So there may be various parameters, but you just didn't have the power to take a look at that. But it's mostly with nothing too obvious came up. And by the way, we just to complete in our center, we have eliminated the clopidogrel loading, but we use a few months of DAPT per the guidelines afterwards.
Oh, so you're still using the DAPT afterwards?
Strictly afterwards, because if you look at the trials, quite frankly, the clopidogrel loading is what's to be incremented, to be incriminated more than anything else. Events are not that big on the way out, and we just don't feel that the guidelines to be ignored at this point. We'll reevaluate later this year.
And Lars, what you were saying, something you had raised?
Yeah, again, we don't know whether this subclinical leaflet thrombosis have any impact, but there's a major difference between a supraannular and an interannular leaflet position. So we have seen that this phenomenon is much more common if you have an interannular position of the leaflets than a supraannular position of the leaflets. And I think one of the factors which is driving it is that if you have a constrained stent frame at the annulus level and you have internal leaflet position, these patients are much more likely to have this subclinical leaflet thrombosis. But then again, we can discuss what is the impact of it. But it's a signal that these valves are more prone to have thrombosis.
No, I agree. And I think this is where also my bias that if you are not fully expanded or cannot fully expand the balloon expandable valves or the intraannular valves, then this is some kind of a risk factor for these valves. And if the valves touch the walls or the sinuses are too small, like in radiation patients or in valve, I think that also probably increases the risk because we cannot align the valves. Commissural alignment is not possible. Kentaro, you have a question?
Yeah, thank you very much. And I totally agree with you, Samir and Lars, that even in our study, balloon expandable valve has the higher incidence of the health compared to the evolute. And for a post-procedure antithrombotic regimen, and we usually use a single antiplatelet therapy. And we have conducted some study to compare aspirin and clopidogrel. And according to our study, clopidogrel did better than aspirin in terms of decreasing the cardiovascular mortality by decreasing the incidence of sudden cardiac death and cerebral infarction. And that was accepted in the circulation intervention. And we also conducted some study to compare DOAC and warfarin. And the DOAC was better than warfarin in terms of the decreasing the all-time mortality. That was also published from our OCEAN registry. And especially in our Japanese cohort, the hemorrhagic event has a much bigger impact compared to the embolic event. That is our strategy.
Do you use anticoagulation for your surgical bioprosthesis?
Yes.
So
we usually use warfarin for 3 months for surgical bioprosthesis.
Because, in Cleveland, we are not using anticoagulation for surgical bioprosthesis for several years, like as far as I have been here, which is 20. So at least it's not a routine therapy. And I know that the guidelines have some guidelines to say that it might be a useful thing to do, but it is mostly directed towards the post-op AFib rather than leaflet thrombosis kind of issues. Lars, you had a question for that?
Yeah, but just back to this surgical bioprosthetic aortic valves. First of all, we don't have the same kind of evidence for these valves as for the TAVI valves, but registry shows that patient actually receiving warfarin for the first 3 months is having a better outcome. But again, remember, there's a major difference between the surgical patients and the TAVI patients. TAVI patients are 10, 20 years older and much more frail in average. So it's a different setting.
No, and also the surgical patients, remember that they have subclinical AF, atrial fibrillation, because you are stopping the heart. So this is a very different kind of population than TAVI population, where new onset AFib is not particularly that common as post-operative because we are not cannulating it. So the other question that comes up, that what are how would you plan a new trial in terms of for leaflet thrombosis to say the durability is, because I think that more or less people are resigning to the fact that the stroke risk is not an important risk with this leaflet thrombosis. But durability part is still questionable. Is in my mind, it stands to reason that you could potentially make the valve less durable if you have leaflet thrombosis, subclinical leaflet thrombosis. So the question is that, well, how do you analyze? Because as you saw in the partner trial, it comes and goes. So what is the best way to analyze this information, and how do you put it together? That what is the importance of finding these things?
I can say that we have launched a study, 700 patients, where we actually do a CT scan at 3 months, 1 year, 2 years, 3 years, 4 years, and 5 years. So first of all, you can try to see this temporal dynamic in the phenomenon, but also to see whether it's going to impact your ability. And also we have this discussion, is it a risk factor for TIA and stroke? So you have a chance to do an additional CT scan if the patient have a thromboembolic events. And I think that's maybe one of the things we're missing in this discussion about subclinical leaflet thrombosis. What is the long-term outcome of it?
No, absolutely. I agree with you.
I think that's an important, very important study that will fill an unmet need, because at this point in time, I have the impression that we still tend to overreact to halt or realm and reduce leaflet motion, and because we don't know, right? And because also there is a plethora of data, but it's not consistent, so we don't know what is the best timing to do a follow-up CT. And if you then are able to design a 700 patient trial with CTs at 3 months, 1 year, 2 year, 3 year, 5 years, fantastic, really fantastic.
No, it's fantastic. So one other mechanistic question is that, in the leaflet, we see the thrombus on the leaflet. There is in the surgical valves and otherwise, even TAVR valves, the commissures do get fibrosis and pannus formation, which is impossible to see on the CT scans. And that can also affect the durability of valves. And this may start as a part of thrombosis. So is there, do you guys, first of all, agree that this kind of phenomenon can happen or not? And if it does, what is the understanding of this?
I'm sure it'll happen, and we have no understanding. I think it's possible, but it's just very difficult to image it in vivo. That's really the problem. There is no question that localized thrombus can ignite a lot of this phenomena, the pannus, the fibrosis, or absolutely. We just have a practical problem of how to ascertain it, and particularly over time. Even with a leaflet thrombosis, I don't think there is anyone who wished we had a less expensive and non-contrast related study to do the job. But we don't. And even the CTA, it is cumbersome, costly, and has some risks. These phenomena are tremendously interesting, and could be very important. We just don't have the tools, I think, right now. We wish we could. Maybe there is another imaging modality we have to invent.
So the question is that if you find a patient who has an increased gradient and you don't find calcification on the leaflet, which is not uncommon, it happens, and you don't see that much leaflet thrombosis, do you dilate it? Because some people are saying that they think this is under expansion of the valve. I doubt that this is under expansion of the valve, because it was expanded before. So then people are dilating it and it gets better. So this is where the question comes to my mind, that our imaging is somewhat limited to understand that what exactly was the problem. And this is the reason why I raised the first question, because there are several people who have so-called reported underexpanded valves, and now they are dilating and it gets better. But this is a serious question in my mind, that this is an underexpanded valve or something else that we don't understand fully.
Yeah, well, I think the number one predictor for those events, I bet you, is a valve implanted in another center than their own. So, absolutely. Somehow, if they ask them, you will see that 99% are going to be some other valves that were not involved in the implantation. And somehow they figure out on second opinion that it may be underexpanded. Realistically, I'm not sure that is that important, the underexpansion, and I don't think that is risk-free. Because who knows what this does to further valve deterioration a little bit later after a transient improvement, and who is also to say that otherwise the valve is free of clots during that time. So I'm not that enthused about this.
But I think it's important, as you said. Go ahead, Nicolas.
Go ahead.
I'm just saying, I think it's important, as you say, Samir, to understand what is actually the reason that you see these valves starting to fail. And we need proper imaging to have a better, a higher level of information. We normally do intercardiac echo with the ICE probe in the ascending aorta, looking down to the stent frame. And it most of the time will give you a better understanding what is the cause of the failure mode.
Nicolas, you're saying something, I'm sorry.
Yeah, I would also caution about caution on the practice of dilating these valves because delayed, when you dilate later after a valve implantation, that might not be a trivial thing. You might cause microtraumata to the leaflets, and that also may come back to haunt you. And I think we need to understand better this phenomenon of leaflet thickening and reduced leaflet motion. And also, I think we need to discern better whether it's different for surgery and for TAVI or transcatheter heart valves, and whether it's also, we discussed briefly the supraannular versus intraannular functioning valves, but also the fact that there is a stent frame in front of coronaries or whatever can also change the flow in the aortic sinuses. That also may play a role. So I think there's so many unknowns so far.
When now 20 years ago, when I was a fellow, we used to do some intravascular ultrasound just for trying to learn a little bit more about aortic stenosis. So with Tuju and I, we did a bunch of valves to see that can we see a little bit better the valve leaflets and whether there is a fusion of the commissure or not, because there was some question raised that people have acquired fusion of the commissure or not. It doesn't exist. Now we know that it is congenital, all these things, but I have not done TAVR valve intravascular ultrasounds to study this, but I'm thinking about doing this for the patients when they come with this kind of a problem where we are not, because it is at least no contrast and it is relatively simple to do. So I think that, and better than intracardiac echo, because the intracardiac echo, I agree that can be helpful, but again, it's very similar to a TEE because you have the same limitations, more or less, of shadowing and things like that. So if you're seeing from inside, you might be able to see it better. Is my at least a theory, and I am at least thinking of trying to employ that kind of idea. But I have not, to be honest with you, I have not tried it much other than in the patients where there are coronary issues. But I would like to put the peripheral IVs, the catheter, which is 9 French. It doesn't matter. 8-9 French is not a big deal. And now there are also 6 French catheters.
Well, I wish I had a flexible angioscope.
Yeah. And 10 years ago or 12 years ago when I was in my fellowship, I did a couple of IVISs with Saros after a valve implant. And we ran into issues with the window that you have, because the current IVIS platforms or the coronary IVIS platforms that we had at that time at our disposal, they don't see far enough, right? They only go up to 10 millimeters.
20, yeah. Nowadays 20, but still not good. But I think peripheral IVIS. So what we do for the TAVR, TAVR, the aneurysm repairs. Those are fairly good, they are, you can see far enough. And maybe easier. Or we can stick the ice inside the aorta. That's another option. So that we can put the ice catheter instead of being in the vein. If we are in the artery, we might be able to see a little bit better. But I have not tried either of this. But because it's 8 French, the ice can be 8 French, it's not a big deal to put an ice catheter in the aorta.
The only big deal is that it is not steerable. So that's, I mean, doesn't have a wire, I should say. It doesn't have a wire. So.
Yeah, but again,
no, we put a long sheet and come out there and then just come out. But it is not long enough. It may not be long enough to reach. That's the issue.
But again, that was what I'm trying to say before. We use an ice catheter in the artery without a long sheet. We just go around the aortic arch into the ascending aorta, looking straight into on the leaflets. It gives you amazing imaging images.
So you are doing it through the arterial side.
Yeah, because because then you don't have this shattering from the frame, and you're looking straight down on the when you flex back on the ice probe.
Wonderful. Yeah, so this is what I was asking, that if you're doing it, that might provide some useful information. In this
also, if you have patients who are suspicious for endocarditis, it can often be difficult to see it on transthoracic and transesophageal echo.
Does it reach, the probe reaches well to the aortic valve?
We don't cross the valve. We're just setting it just at the outflow portion of the stent frame.
You're sitting in the ascending aorta, essentially,
Yeah.
Wonderful. Any other questions, comments, anything?
Well, I think it's going to be an important year for pharma therapy after TAVI this year. But as George mentioned, we have the envisaged TAVI AF, we have Atlantis coming. So I think we are building a scientific backbone to our everyday practice with TAVI. So I think we'll set a major step forward this year.
Yes, so I'm fully agree the Nicolas comment, and still we have a leg of data about for optimal antithrombotic therapy. Although popular TAVR series published in New England Journal of Medicine, less is more. Always, if you select the combination of the bleeding and ischemic event, it's less is more always the winner. Yeah, so the reason why we require the more advanced, the more detailed clinical trial.
So can I have one question?
Of course.
Yeah, because now the indication of TAVI is shifting towards younger and healthy patients. And if we treat the very elderly and the frail patient, I think the less is more. Less antithrombotic regimen is more efficient to avoid the bleeding risk. And do you think we need to have different the antithrombotic regimen for younger or lower risk patients? What is your thought?
Well, I agree that there is a good point that just like anything else, the bleeding risk is down, and so you can potentially be a little bit more aggressive about the bleeding therapies. What do you say, George?
No, I'm going to come back to what Nicolas said earlier, that he's experimenting with a low dose of edoxaban. And again, I'm sure it's along these exact same lines that Kentaro said, that this is perhaps for the low-risk patients, who in general are the low-risk TAVR patients for the most part, not exactly, but almost. And also to point out that in the findings of the Galileo 4D, it was an intermediate dose that produced a significant reduction in the leaflet thrombosis. So one can say, sure, it didn't really work from clinical point of view. At the same time, we know that we don't have to fully anticoagulate in order to prevent this thrombi. Even an intermediate dose is sufficient. Something we did not know, by the way, in the beginning of Galileo, and I could hear a lot of issues and doubts about if we could have any effect with the intermediate dose of rivaroxaban, that only the high doses were to work at the time. And again, those were the times that everybody was very concerned, and people were anticoagulating with warfarin INR over 2.5 and various other things. So no wonder that there was criticism about that as well. But now we know that even low dose works. So maybe we can reintroduce it in a lower profile patients.
Okay, so ladies and gentlemen, my name is Jean-Philippe Collet, and this is my great pleasure to participate to this TAVR and Antithrombotic debates. I'm located in Paris at the Pitié-Salpêtrière University Hospital, and I have to defend the NOAC position. So I would like first to start with the issue of device itself and valve thrombosis. And you can see that there are two ways to prevent valve thrombosis, either using antiplatelet agents if we think that high shear stress is the main participating mechanism for a potential valve thrombosis and dysfunction, or the other one is to use anticoagulants, given the fact that thrombin-based formation in resting areas may happen in the setting of TAVR. And we know that the valve adds itself a prothrombotic environment, and that it is associated when times elapse with thickening of the different leaflets, which may end to reduction of leaflet motion, and this is called the valve dysfunction. And subclinical thrombosis may be also associated with some, I would say, thromboembolic events, although the relationship is not clear-cut. Anyway, and this is, the illustration of, thrombus formation here on the left-hand side, and the progressive hypoattenuation of the leaflets from, the external part, the commissure of the leaflets, up to the central part of the leaflets. And this is quite common and seen in 10 to, I would say, 30% of the patient is not normal. So it depends where you put the threshold. And then the reduction of the leaflet motion may be present in, I would say, 10 to 15% of the patient, depending on the antithrombotic regimen. And we do know some independent correlates of subclinical valve thrombosis, including the exposure to oral anticoagulation, but also to the types of intervention like valve-in valves or the size of the bioprosthesis. So we may identify some patients in whom we should use anticoagulants. Now, second, let's look at the prevalence of events, and we know that in the setting of TAVR, there is a kind of trade-off between two types of events, which are stroke and serious bleeding. And serious bleeding are much more frequent than stroke. And then the occurrence depends, of course, on the underlying risk of the patient. But this is just to outline the fact that we should not be too more aggressive with the antithrombotic regimen, and that safety is very important. And I would say safety first, and this is why NOAC is a good opportunity in the TAVR setting. Now, if we look at what drives the use of antithrombotic therapy, it is mainly the patient characteristics and the concurrent disease, including coronary artery disease, but also concomitant atrial fibrillation that is present almost in 1/3 of the patients. And at the end, if you look at the entire TAVR population, around 1/3 to 50% should be exposed to oral anticoagulation, and the remaining one potentially to the antiplatelet agents. And the question here is whether NOACs may replace antiplatelet agents when there is no indication for oral anticoagulation. And the second question is whether NOACs would be better than VKA. And we know that in the setting of AF, we have evidence showing better safety of NOACs in many big pivotal trials. Now, if we look at the guidelines, either European or ACC AHA, it is clear that there is no place for NOAC, but these are mainly expert-derived guidelines, and you can see that the level of evidence is only C, means that at the time of the guideline release, the scientific evidence was very, I would say, poor. And you can see that at the bottom end of this table that NOAC should be considered as an alternative to VKA, but only after 3 months. And this reflects the lack of, scientific evidence. Now, if we look at now the recent ACC AHA updates, it is interesting that there is very little place for NOAC. And we know from the Galileo that low-dose rivaroxaban should not be used and is not recommended based on the Galileo trial. But you see that in the other setting, even when oral anticoagulation is indicated because of concurrent AF, the use of NOAC is not recommended yet because of the lack of evidence. Now let's see what do we have there. So if the patient has no indication for oral anticoagulation, we have, a very nice demonstration, mainly based on the popular TAVR trial, that a single antiplatelet therapy is much better than dual antiplatelet therapy. It is safer, and outcomes in terms of thromboembolic event does not differ according to SAPT or DAPT. And at the end, when pooling, safety and efficacy outcomes, single antiplatelet therapy should be the default strategy. And what is interesting is that most of the benefit is driven by events that are bleeds, but most of these bleeding events were obtained during the peri-procedural setting. So the question now is whether there is a place for NOACs when compared to single antiplatelet therapy in the real-life setting. And if you look at, the incidence of valve thrombosis and especially reduced leaflet motion grade 3 or 4, which is indicated on this slide, we have the very nice data from Galileo for DCT showing an 8.8 absolute percentage difference of the occurrence of Rayon grade 3 or more when comparing rivaroxaban versus antiplatelet therapy. And the question now is, whether in this particular setting where anticoagulation is not needed, it is associated with better outcomes when considering only subclinical valve thrombosis. Unfortunately, when looking at the outcome of the study, which was prematurely stopped, there were more thromboembolic events when exposed to Riva versus antiplatelet agents, and there were more also bleeds, and this explains why the study was stopped. But the remaining question is that if we have, a similar safety profile of, a NOAC versus antiplatelet agents, the the question is whether the reduction in the observed reduction of leaflet motion is associated with a better outcome. And I think that this question should be explored and remain open. And I would like to remind all the audience that if we look at the Atlantis Trial in the IF population at very high risk and deemed non-suitable for VKA, apixaban was much better than aspirin alone to reduce thromboembolic events with a similar safety profile. So we should, have more data on this specific setting. Now, when there is no indication for oral anticoagulants, the evidence is that adding an antiplatelet agent on top of anticoagulation is associated with harm and is not needed. But if you look at this cohort of popular TAVI, which is very interesting, only VKA patients should have been randomized, but a certain proportion of patients, 25%, were exposed to NOAC in this popular TAVI cohort B patients. And you can see that there is a very nice interaction when comparing VKA versus NOACs, and that the NOACs exposed patient seems to have, an even better safety when antiplatelet agents was withdrawn during the randomization process. So these are very good news for the NOACs versus the VKA, which represent, as I said before, on around 30% of our patient population. And again, when you look at, where is the benefit, it is mostly driven by the reduction of major life-threatening or disabling bleeding by almost 50% without, any effect on, thromboembolic events. Now, what do we have in the real life with NOACs versus VKA in the setting of post-TAVI? We have only small registries, and one comes from a German team. On the left-hand side of this slide, you can see that they compared VKA versus apixaban, after the TAVI in the patients with atrial fibrillation, and they did of course matching of the population, and you can see that there is a trend for less events when looking at mortality, disabling stroke, or bleeds, which is interesting. But these are only evidence derived from registries, and we need to have some more randomized data. And this is also because we have another registry from the same country on a largest population sample size, showing the opposite, with more events in terms of thromboembolic events with apixaban versus VKA, and a similar safety. So we need to explore more in depth this situation of NOACs, but I think that we have some evidence, especially with respect to valve thrombosis. And we have ongoing trials, which will be released in the next few months, which may provide some interesting answers. And this is the Atlantis Trial, where patients are randomized according to the need for oral anticoagulation just after the TAVI procedure when successful. And we are looking here for the standard of care, VKA or DAPT versus apixaban. And the outcome of interest is the net clinical benefit. And in this trial, 4D CT scan are performed in all patients and part of the primary endpoint. So we are looking for, of course, safety, thromboembolic events, including, device failure, which is important. This is a superiority trial, and it may answer, whether, an apixaban regimen at a dosing strategy which is labeled to prevent stroke in the setting of atrial fibrillation will be better than the usual standard of care, which can be either VKA or DAPT or SAPT. It will be released at the next ACCHA meeting in May 2021. So to conclude, I would say that the valves add a prothrombotic environment for sure, that bleeding is the predominant events in the TAVI population, that atrial fibrillation is a strong determinant of cardiovascular events, that single antiplatelet therapy should be the default therapy if there is no need for oral anticoagulation, but that NOAC is better than single antiplatelet therapy for the prevention of subclinical valve thrombosis. And finally, whether NOAC should be the standard of care for patients in need for oral anticoagulation is an open question. And I think that we have two trials, the Envisage trial and the Atlantis trial, which should provide some clear-cut answers. But in the real-life setting, I think that if you have a patient with small bioprosthesis or valve-in-valve with no indication for oral anticoagulation, NOACs may be a good treatment to avoid valve thrombosis. Now, in the setting of atrial fibrillation, we have also the evidence for, from the AF trial showing better safety than VKA. So I think that NOACs has a real place, although not entirely evaluated, and within a short time delay, we will have definite answers. Thank you very much for your attention.
Wonderful. Well, thank you very much again, everybody, and it was a great session. And thank you for everybody's contribution.
Hey, thank you. Thank you. Yes, very nice talk and very nice discussion.